Thanks, Howie, for that introduction. It's a real pleasure to be here today to speak to all of you, and it's wonderful to see such a turnout here. And thank you for all your support and all the time that you've provided to our research center. It's just been a remarkable experience being here for the past 7 years to see the program grow, largely thanks to you. The reason I'm speaking to you today about genetics and dementia is I'm a behavioral neurologist, and my primary research focus is studying the genetics of frontotemporal dementia with neuroimaging. And there are many people at our center who are very interested in genetics, and as Howie said, one of the reasons that this is the case is that because with knowing and identifying a gene, we're able to sort of see what happens either in the earliest stages of disease or even before disease starts. And what I'm going to talk to you today is a little bit about the concepts behind genetics and how we think about them in relation to disease, and give you a bit of a background while touching upon some of the exciting research projects that we're anticipating in the future. So first of all, just wanted to give you a little bit of background of some of the jargon that we use in the medical field. So sporadic versus genetic disease. So when we talk about sporadic disease is caused by multiple factors, genetics, environment, and the interaction of these factors is not necessarily completely understood, and there's often not a clear family history. Now, we talk about genetics. People often come to me and say, my patients, well, I had this one relative in my family that had Alzheimer's disease, for example. Does this mean that there's genetics in the family? And I think the way we think about genetics is kind of in two camps. So one camp is known disease-causing genetic mutations, and then the other camp are genetic risk variants that may modify, increase, or actually decrease the risk of disease in some cases, and we're hoping to understand more about that in the future. So the genetic mutations are disease-causing mutations known to directly cause a disease. If you have the mutation, there's a high likelihood, in most cases, depending on the gene, that you will develop the disease. And these genes are very rare in the population. They confer a strong risk for the disease, even though they're rare. While on the other hand, the genetic risk variants might increase risk for disease, but this causal relationship is not exactly clear. And these are very common in our population, but they actually have a weak risk for disease. And so overall, across all diseases, not just neurological, not just neurodegenerative, sporadic disease is much more common than this disease-causing genetic mutations that we've identified. I think the future really in genetics and disease is to understand what these genetic risk variants are. They're common, there are many of them. You can imagine if you have a list of some that increase risk or another list that decrease risk, it's kind of like this calculation that we're trying to assess risk for each person. This is an area that the field is heading toward, and we're not quite there yet, but I think it's pretty exciting for the future. So I think, so for example, in Alzheimer's disease, there are known disease-causing genetic mutations that I mentioned before. The three known genes are occurring in very few families, and they're called amyloid precursor protein, presenilin 1, presenilin 2, and all of these genes are involved in the formation of that amyloid protein that Bruce Miller was just talking about, the protein that is found in the brains of people with Alzheimer's disease and is also identifiable by those PET scans. And in this story, the symptom onset is in the 50s or even earlier in the families, and each family member has a 50% chance of inheriting the gene. And this is a very, very sort of rare scenario. And often these families have a sense of who they are, because there's a lot of Alzheimer's disease really affecting individuals in the family very early on. And this is less than a few percent of cases of Alzheimer's disease overall. Now, the other scenario, the genetic risk factor, the most commonly known one is apolipoprotein. And, Alzheimer's disease research centers are always trying to identify new genetic risk factors that may increase or decrease risk of disease. But this is the one that has consistently been shown to increase risk. And this is an apolipoprotein, which is involved in cholesterol metabolism. It's not to say if you have high cholesterol, you have this or has a relationship to that. Sort of the reason that APOE4, which is the risk gene, increases risk for Alzheimer's disease, it's not really known why. we know that it doesn't directly cause the disease, and people with APOE4 will not necessarily develop Alzheimer's disease. And therefore, it's currently not recommended to get genetic testing for APOE4. But I think that there are some really exciting disease-modifying therapies in the future. So for example, Bob Maley at the Gladstone Institute at UCSF is actually looking at a drug treatment specifically for people who have this APOE4 risk gene to turn it into the gene that looks like it doesn't increase risk for Alzheimer's in the people who carry the gene. So in the future, I think that even though we are not recommending genetic testing for these things, once these treatments become available, it's going to be a game changer. So stay tuned for that. I'm just going to touch briefly on the genetics of frontotemporal dementia, my area of interest. So as many of you know, frontotemporal dementia is one of the more common dementias, or either the most common or tied with Alzheimer's disease for those who are under 65 years old. And there are three known disease-causing genetic mutations. One is in the tau gene, so the tau protein that Bruce Miller was just speaking about. And there are two other genes. One is called progranulin, and one is on chromosome 9, and it has this name C9ORF72. And the point is that these three genes cause different types of protein deposits in the brain. And similarly to the autosomal dominant genes in the Alzheimer's disease, each family member has a 50% chance of inheriting the gene. So the question is, well, when is genetic testing warranted? So your physician, your genetic counselor may suspect a disease-causing gene, and in that instance, for example, maybe perhaps relatives in the family in more than 2 generations on the same side of the family may have a degenerative disease, so that's one scenario which may warrant testing. And diagnoses occurring at very young ages, usually before 60 to 65, is another sort of indication that genetic testing may be a good idea. But I just want to emphasize that having one relative with young onset, meaning under 65, Alzheimer's disease, it doesn't necessarily mean that there is this disease-causing genetic mutation in the family. And similarly, if you have one relative with Alzheimer's disease, no matter what age they are, it doesn't necessarily indicate a genetic risk factor, identifiable genetic risk. So I think that when we think about genes, the family history is a clue, just to sort of think about degenerative diseases. Sometimes we also ask about psychiatric symptoms as well as early manifestations of disease. And this is really a clue to try and help us figure out, piece this puzzle together. Oh, as I mentioned before, the APOE, apolipoprotein E genetic testing is not recommended. It cannot predict illness, and currently the treatments are not targeted to the APOE4 carriers, but I think this is going to change soon, possibly even this year, coming up soon. So just want to emphasize again, a person with APOE4 may never get Alzheimer's disease, but a person without APOE4 can get Alzheimer's disease as well. So that's the reason that the testing is not currently recommended. So overall, what can we do? I think stay tuned for the research. Genetic causes are really helping us to understand the mechanism of disease and therefore inform drug trials into how to get at that mechanism to block it or obviate it. And I think what I tell everybody, no matter whether they're considered a normal control or healthy person with no cognitive complaints, someone with mild cognitive impairment, someone with active Alzheimer's disease, you should really consider exercise as part of your treatment. And I think we all could do this a little bit better. Every time I say that, I feel a pang of guilt for myself. But it's really important. Exercise is the medicine for the brain. I think there are many studies that indicate that when we exercise, our bodies create these chemicals that they've actually measured in the blood that are protecting the neurons. And so right now, the drugs that we have that are FDA approved are not even as good as exercise, I think. But I think, with this exciting news about the Alzheimer's trial, this is going to change very soon. And of course, to keep your mind active, all of these things are, that you would logically want to do. And again, research can be a way to sort of monitor and get feedback. So I just want to say, oh, sorry, this got cut off, but thank you to everybody here. None of this research would be possible without our active participation from patients, family members, and it's just been a remarkable experience to be able to share with you. So thank you very much.